Good evening, everyone. Sorry to be keeping you here still. Hopefully it'll be brief only. My name is Dr. Zain Masla. I'm one of the senior house officers from St. James's Hospital in Dublin, Ireland. So I'll be talking about a retrospective cohort study titled Evaluation of Echocardiography, Appropriateness in Acute Health Unit. All right, so a bit about the background. So cardiac point-of-care ultrasound or POCUS is essentially a bedside transthoracic echocardiography or echo, and I'll be using them interchangeably. In acute medical unit, so the AMU functions as a unit to help evaluate patients rapidly and providing urgent assessments with an aim to facilitate either same-day discharges or a short stay in the hospital. Cardiac focuses offer a rapid bedside cardiac assessment, which gives us a real-time look into the cardiac function. And this will help the clinician to offer immediate decision-making with regards to the best management to be given to the patient. And although it seems that overwhelmingly it offers a good benefit, there has been a concern that was raised with regards to the appropriateness of the usage of the bedside echoes in the clinical setting. And this has been addressed by the formulation of the appropriate use criteria, known as the AUC, that was developed by the American College of Cardiology in conjunction with the American Society of Echocardiography back in 2011, with the aim is to help to formulate a guideline to reduce the risk of unnecessary echocardiographies that are done in the clinical setting. So there has been limited data on cardiac focuses done in the AMU setting because previously most studies were done only in ED or ICU settings. And this has been the first Irish AMU study that has looked into the appropriateness of cardiac focuses. Our objective was to assess the appropriateness of these bedside echoes that were done in our AMU against the established 2011 ACC/ASE appropriate use criteria guideline. And we had evaluated essentially whether the bedside echoes that we had done were in line with the AUC. This study was done in a model for teaching hospital AMU in St. James's Hospital in Dublin, one of the largest ones in Ireland. And the bedside TTs were consultant-led. And these were urgent assessments done with hopes to expedite discharges on the same day or short stay for a few days in the hospitals only. So this was a retrospective review of 93 TTs that were done from July to November 2022. We had looked into different variables, including demographics, NT-proBNP levels, significant findings, and length of stay. And we essentially had extracted the data using the electronic patient record. And using the AUC, we classified them with respect to the appropriateness, whether it's appropriate or inappropriate. So we had used SPSS version 22 for the statistical analysis. And we had used non-parametric tests. For the continuous variables, we had used the Mann-Whitney U, which was presented as median, interquartile range or range. And for the categorical tests, we had used Fisher's exact test for a sample size of less than 5 or the chi-square test. And the significant statistical was set at a p-value of less than 0.05 or alpha of 0.05 as a two-tailed significance threshold. For the results overview, we had reviewed 93 TTEs that were done within that time frame, and 81 of them, which brings to about 87.1%, were appropriate. 12 of them, which were 12.9%, were deemed inappropriate, and 10.8% of them required further departmental follow-up echo. So this is just a slide to give guidance on the oncoming slides. So it's about the color coding of the significance level. So green means that it's significant with a p-value of less than 0.05. Orange is borderline at 0.05 to 0.07, and red is insignificant. So looking into the patient characteristics, to start off with is the age group. So if we look into the comparison between the appropriate versus inappropriate, the median age group for the appropriate scans were 72 versus 54 for the inappropriate scans, with a p-value of 0.062, and a subset of that, which is a cohort of patients over the age of 75 years old. There were 33 of them which had undergone the bedside TTEs, and out of those 33, 32 of them were appropriate, with only one of them being inappropriate. And while this did not really meet the significance of 0.05, it was showing a trend towards it. On the other hand, there was no notable significance that was seen in the sex. So I would like to focus on the green rows there. So we can see that for a few indications, which are query infective endocarditis and hypertension, respectively, their p-value were 0.015 and 0.027. They were more statistically significant in the inappropriate group. And the syncope and pre-syncope workup were also showing a trend towards being statistically significant at 0.069. And the rest, we can see the acute PE, chest pain, new atrial fibrillation, palpitation, post-PCI and TAVI, and shortness of breath. They were all insignificant because most of them were appropriate indications anyway. So looking into the echocardiographic findings in both of the groups, we can see that in the appropriate scans that were done, 38.3% had shown significant findings versus only 25% in the inappropriate scans. So this means that 75% of scans, which were deemed to be inappropriate, showed that either it was normal or it was only minimally significant, which point towards a waste of resources in the healthcare system. There was 10.5% of them which required further departmental echo. And a few of them, unfortunately, were duplicate who come to the AMU, getting the bedside echoes, were also booked for a departmental echo in the cardiology department, which can and should have been avoided. So this is looking specifically towards the patients with heart failure. So we can see that comparing the appropriate versus the inappropriate group with regards to the usage of NT-proBNP level, the level was much higher for the appropriate group at 862 picogram per milliliter versus only 56 in the inappropriate group, with a p-value of 0.032. And to further look into two separate guidelines, to look into the cutoff value for the NT-proBNP level. So the first one is the European Society of Cardiology 2021 guideline for non-acute heart failure. The NT-proBNP level cutoff was set at least 125. So 32% of patients who underwent appropriate echoes had met that cutoff point versus 0% in the inappropriate group. And the second guideline that we had referred to was the local Irish HSE guideline 2021 for non-acute heart failure, with a cutoff pro-BNP level of 400 or more. It showed that 26% of them had met the cutoff in the appropriate group versus 0% in the inappropriate group. For the inappropriate cases, majority of them was for syncope workup, holding a high majority at 42%. Next one is hypertension, 25%, fever at 17%, and 8% each for leg swelling and murmur. For the follow-up departmental echocardiographies that were done, there were 10 of them. And we can see that within the 10 cases, 30% of them showed significant findings, and 40% showed moderate findings. And we can also look into the appropriateness, whether they were even needed to be done after the initial bedside echo. We had found that 70% of them were justified, with 20% of them being duplicative. And the 70% were either two of them being a follow-up of a query PFO for stroke workup. And there were also patients who had developed new symptoms and worsening of their acute decompensated heart failure. So for discussion part, so most scans that we had done in our service were appropriate, aligned with the appropriate use criteria. And they were mostly linked to heart failure, atrial fibrillation, chest pain, or dyspnea. And cardiac biomarkers in the form of NT-proBNP supports the triaging of these scan requests. So these appropriate scans, they add real value, often influencing diagnosis and help to expedite discharge in the hospital. For the inappropriate use, there were 13% of them, and commonly they were for syncope workup, hypertension workup, ineffective endocarditis with no features seen clinically. So these are the ones that rarely alter management, and they risk to waste resources and hold a very low diagnostic yield. So strengths and limitations. So this is the first study that was done in Ireland to look into the AMU usage and appropriateness of the focuses. And we had used it against a well-established and objective AUC criteria. And we had also integrated a cardiac marker in the form of a NT-proBNP. Limitations include it is a retrospective study, a very small sample size, apologies, and there's a single review bias and no cost analysis that was done, which we hope to do in the future re-audit. Implications and take-home messages. So POCUS is a valuable adjunct in the acute medical unit setting. Most scans that we had done were appropriate, although some were low yield. AUC and NT-proBNP improves triaging, and continued education and integration of an appropriate triaging system in the same department helps to reduce duplication. And in the future, perhaps, with the growing influence of artificial intelligence, and not only in the world, but specifically in the healthcare industry, we perhaps will see more influence of AI-assisted focus, which may help to improve diagnostic power. In conclusion, so cardiac focuses that were done in our service were appropriate in 87%. And looking into the literature that was done previously in different settings, which include both inpatient and outpatient service, it was ranging in between 71 to 96% of AUC adherence. So we are definitely going towards the right direction, but things can definitely improve. And biomarkers correlated with appropriateness level. And we had seen that inappropriate scans yield little benefit. And this highlights the importance of structured triaging tools, which will help to improve efficiency of the service and also utilization of appropriate imaging for the patients. Thank you.